Welcome, and thank you for watching this important video discussing the evidence on non-invasive ventilation and COVID-19. My name is Dr. Emmanuel Ayevale. I am a clinical instructor and fellow in global health and anesthesiology at the University of Washington in Seattle, and a technical advisor on the USAID-supported UCSF STAR COVID-19 Technical Advisory Group. We will start off by defining the important terminology used in describing non-invasive ventilation, then delve into the specifics of each modality, discussing the current evidence for and against their application in treating patients with severe COVID-19. In addition to high-flow nasal cannula and mechanical ventilators, continuous positive airway pressure, or CPAP, and non-invasive positive pressure ventilation, or NIPPV, describe oxygen delivery devices or ventilator modes capable of delivering both pressure and supplemental oxygen to patients at high flow rates. High-flow nasal cannula delivers very small amounts of pressure, whereas NIPPV and mechanical ventilators provide pressure that can relieve the work of the respiratory muscles. Non-invasive oxygen delivery devices can deliver high concentrations of oxygen, but have potential limitations, including some risks to patients, as we will discuss later. The terms CPAP and non-invasive ventilation, or NIV, are sometimes used interchangeably. They are, however, different. With non-invasive CPAP, a face mask or other interface is used to apply a pressure greater than atmospheric pressure to the proximal airway. The result is splinting open the upper airway, increasing lung volume, and increasing intrathoracic pressure. With CPAP, there is no inspiratory muscle unloading. In fact, tidal ventilation remains completely dependent on the respiratory muscles. The terms NIV and NIPPV can be used interchangeably. NIPPV, commonly referred to by the trade name Bi-level Positive Airway Pressure, or BIPAP, applies a pressure during the inspiratory phase that is greater than the pressure applied during exhalation. NIPPV thus unloads the respiratory muscles and can provide complete respiratory support. Though most modern mechanical ventilators provide both NIPPV and CPAP, there are also devices designed specifically to deliver either NIPPV or CPAP separately. There are significant differences in performance among these devices, depending on how well they compensate for large leaks around the delivery interface and how well they respond to patient triggering. There are many home CPAP and BiPAP devices that are unable to treat patients with severe acute respiratory failure, either because they do not accept high-pressure oxygen, lack appropriate alarms, or do not have easily adjustable settings. Their suitability for treating less severe forms of COVID-19 remains undetermined. However, there are some devices that are designed exclusively for NIPPV and can therefore accept a high-pressure oxygen input. There are multiple ways to deliver CPAP and NIPPV. The oral nasal mask is usually the most common initial interface in terms of leak prevention and patient comfort. Delivery by mask requires a tight seal to avoid a leak. Leaks may contribute to aerosolization and healthcare worker risk. The seal is important to maintain a constant pressure in order to receive the benefits of this modality. It can be very uncomfortable to tolerate wearing these masks over several days, and frequent breaks and repositioning are necessary to avoid skin breakdown and to promote patient adherence. CPAP or NIPPV can be delivered by a specialized helmet, which is more tolerable but requires higher oxygen flow rates, and the helmet setups are not readily available. Boussignac CPAP is a flow-dependent, low-cost CPAP system commonly used to treat cardiogenic pulmonary edema. It is unable to provide a fraction of inspired oxygen of greater than 50% and is prone to significant leak and patient discomfort, thus limiting its use in treating patients with severe COVID-19. Early interest in CPAP during the COVID-19 pandemic arose for several reasons. First, there were early suggestions that COVID-19 respiratory illness may have a different physiologic profile than typical severe acute respiratory distress syndrome, or ARDS, and could potentially respond to CPAP better. Further data has yet to fully support this theory. Second, in some settings which experienced surges of patients with severe COVID-19 and a shortage of mechanical ventilators, non-invasive machines like CPAP were used, with initial non-randomized and often largely anecdotal reports giving hope. Robust data on outcomes to support the widespread use of CPAP in treating patients with severe COVID-19 remain lacking as of September 2020. Third, early reports of intubated patients with severe COVID-19 suggested mortality was very high, spurring desire to defer intubation as much as possible. However, subsequent data has shown that mortality in intubated patients with severe COVID-19 is likely similar to that of non-COVID-19 ARDS and possibly even better. The highest reported mortality rates are likely attributable to overstressed healthcare systems rather than an inherent characteristic of COVID-19 respiratory failure being more lethal than other types of ARDS. There are, however, some evidence-based uses for CPAP and NIPPV that have demonstrable benefit in treating certain conditions, including chronic obstructive pulmonary disease and heart failure. Data for NIPPV and CPAP in many other conditions continues to evolve, often with mixed results from trials such as those studying the potential benefit of CPAP and NIPPV in treating immunocompromised and obese patients, as well as preventing re-intubation in patients weaned off mechanical ventilation. Physiological studies have shown that the helmet interface decreases air leaks compared with face masks. Decreased air leaks may allow for more effective delivery of higher levels of positive end expiratory pressure, or PEEP, potentially increasing alveolar recruitment and decreasing respiratory effort. Patients with acute hypoxemic respiratory failure may also have better tolerance for a helmet interface compared with other strategies, thus minimizing interruptions in therapy. However, strong evidence to support the widespread use of helmet CPAP remains lacking. Several studies have shown an increased likelihood of intubation, invasive mechanical ventilation, and higher mortality when NIPPV and CPAP are used as the initial treatment modality for patients with severe ARDS. This association is even stronger among patients with ARDS caused by coronavirus infections like MERS and SARS. Most of the evidence on CPAP and NIPPV in respiratory failure predates the COVID-19 pandemic and may therefore not translate to treatment of COVID-19 patients. Even though NIPPV and CPAP have been used around the world to manage patients with severe COVID-19, all published data on the use of NIPPV and CPAP in COVID-19 thus far have been observational, and in the absence of randomized controlled trials, conclusions are limited. Some modeling studies have shown that if there is a mask leak, the high flow generated by NIPPV or CPAP devices to compensate for the leak may force infected particles out into the room and increase dispersion. During the 2003 SARS coronavirus outbreak, many healthcare workers became infected due to failure to implement adequate infection control precautions, especially when performing aerosol-generating procedures. However, because of the limited number of studies reporting NIPPV use during the SARS pandemic, the risk of infection could not be established with certainty. Moreover, in a Singapore study of the SARS outbreak, the institution of rigorous protective measures for over 200 healthcare workers, including installing air purifying respirator units, resulted in 0 cases of infection. CPAP or NIPPV for patients with severe COVID-19 could potentially expose healthcare workers to infectious viral particles, especially where personal protective equipment and isolation rooms are limited. Unsurprisingly, given the lack of data, international guidelines on the use of NIPPV or CPAP in the treatment of severe COVID-19 remain varied. In conclusion, NIPPV or CPAP may be able to help a small subset of patients with severe COVID-19, but with many caveats, including potential to harm patients and healthcare workers. Currently, no high-quality evidence exists that is specific to COVID-19 and NIPPV or CPAP. For most patients with acute respiratory failure due to COVID-19, NIPPV or CPAP are not a replacement for intubation and invasive mechanical ventilation when indicated.